So those are the, I suppose to the back, but it's not study very well. You are studying very well. These are the values you are showing now. But not on what the BMI.
I don't know, maybe body mass index. Okay, well it shows you, it's a scale, it shows how underweight, overweight, or medium weight are by measuring the height, weight, and gender.
Gender?
You know, on the calculator it has gender.
Okay.
And so you, the gender is only yeah, I know. In my percentile, I'm good.
What is your percentile?
Percentile, like 19. Yeah, I think that
90, huh?
yeah.
Yeah, so we calculate the BMI based on height and weight. Okay. The square. So you can make by height square. Square it out on height centimeters. So based on that, we calculate what is the BMI. Your BMI should be anywhere between 18 and a half to 25. That's a normal range. For Indians, unfortunately, we are still Indians. Okay, you might think Americans, but you're still Indian. Instead, you're genetically close to Indian. You are still the BMI, normal BMI is only 23.5. Anything above that will be overweight. Okay, this is too much. I don't need. Okay, so for Indians, because of this BMI more than 25. This was back in India actually. Yeah, forget me. This guy doesn't have that. Multiple.
Can you turn those lights on?
That's good, that's good. It's not
He's saying that.
oh, for him.
Okay. I guess I don't have that slide. So I have this slide in this one. The Indians, unfortunately, BMI is 3.5 or above is overweight. 27.5, we start calling overweight, people obese. Anywhere between BMI, in America, for Americans or Asians, white people, anywhere between BMI 25 to 30 is overweight, more than that is obese. And I'm here to talk about obesity awareness basically. I do a lot of general surgery actually with the new medications that have come up with Ozempic, Zepbound. They have taken over a lot of my practice, so to speak. So surgery is still the gold standard with the most effective weight loss for people who have the most overweight. But medications have come over, so my practice is more general surgery now. I do a lot of general surgery, hernias, gallbladders, colon, small bowel, everything in the abdomen. So today, this is not my objective, I actually this practice. Okay. So this is when we're talking about BMI 18 and a half and less of underweight. I'm sure this kid is like 17 maybe. What's your BMI? You know, you know that had not a physical recently? No? 5 months ago? Okay. How much do you weigh? I'll tell you. 130. And how tall are you? Okay, fine. Your BMI is like 19, 20, most likely. So based on that, we calculate. These are the Asia Pacific, their numbers are. We used to think the same American standards, we can carry on to the Indian standards, but over the last 25 plus years, our Indian standards have come up and say that no, Asia people have significantly different obesity pattern and mortality because of the obesity itself. This is the epidemic from India. I know this is all about Indian diaspora, so I still think that it's more relevant for us. Obesity is increasing a lot in India, and the Indian population that comes up here also is slowly getting overweight. So you can see the BMI is going up in the last 10 years. Now it's probably 2025. I don't have the data right now, but last 20 years it's gone up. You can see the average BMI for older population is getting even higher and higher. Younger population is still holding up well, but as we get in the 30s and 40s, our BMI goes much higher. This is the Indian map showing the BMI, people who are more than overweight, percentage of people who are overweight, 1988, 25 years ago to now, it's already turning red, especially our South Indian states, really taking up the hit of obesity itself. So, why why do we need to worry about the obesity? Obesity itself is associated with multiple health problems that we see in general. You see the comorbidities, loss of life expectancy. And this is the one that I like to show off the consequences of obesity itself. It affects the body head to toe. You think of smoking as the leading cause, now the obesity is getting there too. You have from head to toe, you have migraines, depression, sleep apnea, from the lungs you get increased asthma, shortness of breath, heart, everything metabolic disorders, the cardiovascular disease, hypertension. From the stomach you have the reflux, heartburn, diabetes mellitus, in women, stress incontinence, polycystic ovarian disease, infertility is very common in women to do, obesity, digital joint disease, venous stage disease in gout. This does not even include the risk of cancer that is going up right now because of obesity. All the cancers, pretty much almost all cancers are much more prevalent in obese people than in non-obese people. As BMI rises, there is the prevalence of comorbid conditions. So if your BMI is low, your diabetes risk is 4%. If your BMI is 40 or above, your diabetes is 22%. We as Indians, we also have an increased risk of diabetes from a genetic component and from the dietary patterns. So that adds up to, if you have genetics and obesity, the risk of diabetes goes up significantly higher. The chronic heart disease is not much, but the hypertension, obviously, you can see it goes up and up like that. So this is the obesity in India. Same thing carries on out the Indian diaspora here. Diabetes mellitus, same thing. If you're younger, the risk is lower. At lower BMI, the risk of obesity is lower, but as you go, it's higher. Yeah, I think this is the important thing that I talk to about people is that the premature death. So when you include all the health factors, all the consequences of obesity combined, you end up dying 4 times higher than normal weight controls quickly. The cardiovascular disease increased 50% for obese and 90% for class 3 morbidly obese. How can we lose weight? This slide when I made up, I'm practicing bariatric surgery back in India. I was trying to promote surgery as such. What do we do for obesity treatment itself? The basic terms is always a diet. People talk about, oh, we need to go on a specific diet, keto diet, fasting diet, 16-hour diet, fast, whatever. I typically tell people it's not that way. Diet is when I say is that good calorie, good nutritious food in a timely fashion that you can maintain for the long term. Most of the diets that you always do, you see patients who lose like 20, 30 pounds, and then after 6 months of 1 year they gain another 20, 30 pounds. That is not the kind of diet we want you to have. Those yo-yo mechanisms also increase the stress on your body in general. So I want you to pick up a diet, or whether it's even the Indian diet, but pick up the consistency, schedules, eat the way that you want to for your life, and eat small amounts, or quantity. Basically, is to decrease the quantity of calories that you get, but make it in such a way that it does not make drastic changes, because those usually don't work long term. Exercise is part of a lifestyle change. You want to keep yourself active. Medications, these are the non-medications. This is like 5 years ago. The current medications are much more effective for weight loss. The latest ones we talk about are you see the Ozempic and the Zepbound, the Manjaro, the same thing. Those are the ones which we strongly recommend right now for GLP-1 analogs. They have shown up to 10 to 20% of your body weight. So let's say you're 200 pounds, you can easily lose around 20 to 30 pounds with those medications. They also control your diabetes. So right now, most insurance would approve if you have diabetes and obesity. The problem is that the catch is the co-pays right now. They're costing you between $50 per month to almost $500 per month for these medications. So they are very expensive, but they're coming up right now. The weight loss is, like I said, 10-20%. Most of them make you lose weight by feeling you feel full, not want to eat much, hungry, it takes the appetite and the hunger away. Usually those are once a weekly injections. We take it as a diabetes shots, and then usually they take it on the weekend. I tell people patients Monday, Tuesday, and if you want to eat anything because you're just feeling full and stuffed up. That's how it makes you lose weight because you end up decreasing the calorie intake. How are they useful long term? I'm not so sure. This was before the GLP-1 unlocks. You can see that the percentage of weight loss was much lower at that time. Even now, it's like 10% weight loss. If you have 200 pounds, that's absolutely fine. 20-pound weight loss is good for you. But I deal with the American patients and even Indian patients who are 300 pounds, 200 pounds, 500 pounds. For them, this does not work very well. For them, the weight loss really works the best. The surgery treatment is for BMI more than 40. For Indians, the BMI, that's what I talked about, BMI 37.5 or even 32.5 with commodities. So I'm actually surprised to see our Indian diaspora here in Bangalore, especially when I see some of the patients for some other health problems. It's not uncommon that you see a patient with a BMI 35, 40 with diabetes and coronary heart disease already at the age of 40 or 50 here in the US. So you should seriously consider weight loss, whether surgical, medical, diet, exercise, but something that works best. Surgical treatment works best because even if your life expectancy is more than 5 years, your success of the weight loss surgery is better and your life expectancy is much better already. This for the high school kids here, just for fun. The weight loss surgeries, I don't think anybody cares about it at this point here. You don't need all this stuff, the band, the sleeve gastrectomy. I want to just run the video for this fancy surgical video for these guys in the background. As far as the surgeries are concerned, I do them all laparoscopic. We have the new robot nowadays, we use a robot. We take the stomach, let's apply to it, we take it down, make it into a small stomach tube. Let's say your stomach is fist size, or make it a down small size. Around 70% of the stomach is taken out. You feel full because you don't have that stomach, empty stomach calling for food all the time. You don't feel the hunger. You end up losing weight. On average, people lose around 50% of their excess weight. So let's say you have 300 pounds, you lose at least 100 pounds with these surgeries. So here you can see I'm taking the stomach out. Those are the fancy staplers. Somebody wants to see them, they can come to my surgeries in Mercy. Fancy metallic instruments. Interesting idea that those staples are made of titanium, more expensive than gold, but those titanium clips are very inert. You won't get jabbed when you go through the X-ray machines of the airport. But yeah, so you divide the stomach like that, take it out. The stomach looks so small. This is the basic surgery. This is the most common and basic surgery that we do for weight loss surgery. There are multiple risks and benefits for all of these. There's something called a gastric bypass, there's something called a mini gastric bypass, and then the duodenal switch. The myths, these are all medical lingo too much. I think this is one from India that I really was interested to see. Back in 2014 only they started doing their studies back in India. It was still gastrectomy. You can see compared to a lifestyle modification, we can see the BMI change was 11.3 versus 3.3. Weight loss was 28 kilograms for the sleeve and 8.6 kilograms for the diet and exercise alone. So this is an interesting one. Overall mortality I talked about. We do not chance of you dying in the next 10, 15, 20 years. Let's say if you're overweight and the chance of dying in the next 16 years is around 15% chance of you dying with the weight loss surgery because you lost all the weight and all the health problems have been better, the chance goes down to like 8%. So this is the longest study they do in Sweden, which is the best study, but yeah. And all the comorbidities gets better. The same picture that I did earlier, you can see the migraine does 15% result, depression 55% result. Everything in the body gets better with the weight loss, and there's an 18% reduction in 5-year mortality. Quality of life also improves in more than 90% of patients. This is for patients who have BMI more than 35, 40 with diabetes. I think in the Indian population, if your BMI is 37.5 or so, and you have diabetes, which is very common, you should consider weight loss surgery. Not that many patients do, but you should consider that. That's the best for the long-term aspects. This is what I do as a bariatric surgeon for the obesity itself, make sure you lose weight. As far as the general surgery is concerned, I also do a lot of general surgery. Our Indian diaspora, especially come with inguinal hernia is a very common condition. 1 in 4 men develop hernia in their lifetime. It's very common. It's nothing to worry about. But I do laparoscopic surgery. I fix the hernias. Usually overnight stay or same day heart surgery, go home the same day kind of a surgery. Then many patients also develop gallstones, gallbladder diseases. We do gallbladder surgery. That's also one thing we do routinely. If you have any general surgery as lumps and bumps, I take care of them. Hemorrhoidal disease, we take care of them. Yeah, that's what as a general surgeon I do. Any questions so far? Well, these are all the complications of weight loss surgery as such. But I think these are good ones. You can lose weight just by dieting or eating less. So this is what I had some myths that I broke up. If you look at the percentage of weight loss and all that stuff, once your BMI is more than 35 or 40, the success of my diet and law is not that great. Weight loss is an easy way out. Patients think of weight loss as like an easy way out to cheat and lose weight. It's not that simple. It's a human change, and we are a liquid diet, and I think you're getting surgery is only a tool that helps you lose weight. You have to make the dietary changes. You have to make the effort to control your diet and calories, increase exercise, make your lifestyle change to be successful for weight loss itself. My partner used to mention that it's like your fancy BMW car, you get it. If you don't put the petrol in it, if you don't put the gas in it, it's waste. But for it to work, you need to put the effort. The other thing that you talk about is most people will gain weight back after weight loss surgeries. Just like any other disease, any other diet or pattern that you do for weight loss, everything will, some amount of residue regain will be there. So you see the weight regain, the most weight you lose, but some weight regain is always there. Banding is not that successful. The sleeve and the bypass are the most successful ones. But you can see some weight regain is there, but if you consider compared to what we lost, it's a significant weight loss, and the significant benefits are carried over with the weight loss even then.
Just to thank you, Dr. This great presentation. I have a question. Why is it that the new needle switch seems to be in favor nowadays relative to the other ones?
Yeah. So this is a complex question you guys don't understand, but we'll talk about as well. But I'll tell so the diagonal, not the diagonal switch, but it's called a modified diagonal switch. That's more prevalent right now as far as the surgeries is concerned. So let me go through real quick. The advantage of the modified the diagonal switch is compared to the bypass is there. So this is quick rundown. It is a normal stomach. We used to put a band across to make you eat small. We don't do that anymore. This is a sleeve that the video that I showed you the staples. This is the gastric bypass, small pouch and a small. We only divert around 1/3 of the bowel with the gastric bypass. Unfortunately, what I noticed is that the amount of food that you eat with the gastric bypass, we initially have a restriction with the pouch with a small amount, but after a while, this pouch acts as a conduit only. The entire jejunum where the anastomosis is, so opening is this big. The patients eat food. They're not storing in the stomach. They're storing in the jejunum. They're storing in this ruling. So this whole thing acts as a storage, so to speak. If the patient doesn't really do good, they can eat almost as us after 1-2 years. So the weight loss is not that big. And it's only 1/3 of the bowel that is diverted. We have 20 feet of small bowel. We're diverting what? 6 feet, 8 feet the most. Your body can absorb all the calories that you get in. So the malabsorption is good for the first 1 year or so. After that, it kind of slows down. This is the diagonal switch that we're talking about. This is the most advanced, the actual diagonal switch picture where you have a sleeve. So even if you eat whatever you want to eat, this is not going straight. You have the pylorus that will hold up everything. So you cannot eat more than like with the gastric bypass. Number one. Number two, here we are bypassing almost 7/8. In the true diagonal switch, we are bypassing 7/8 of the bowel. You only have 3 feet. The common channel is only 100 centimeters. It's only like 3 feet. You will not absorb. Even what we have noticed is that the early weight loss in weight loss surgeries is because of the restriction, so you lose that, but the continuing maintenance of the weight loss is from the malabsorption. The deodorant switch really keeps the malabsorption. You have 2 to 3 power months a day, you will be shitting out your food, basically. So you end up maintaining the weight loss. It is the most malabsorptive, so the high risk. So what actually came up with the modified switches, instead of doing the common channel 100, we make the common channel around 200, 250, 300, depending on that. So it's around 6 to 8 feet of common channel. But still you have the sleeve restriction and the bypass. So it's kind of a good of both, the bypass and the PPD. I think it's like in the middle of these two. Weight loss is good, but the malabsorption is not that bad. We used to say protein malabsorption of 10% with the PPD. We have patients who have liver failure because of the PPD. Now we don't see that with the modified deodorant switch. That's the advantage of the modified switch. The other thing that is more, I like it with modified switch because of diabetes. So diabetes resolution after the gastric bypass is from the rerouting of the bowel, that we call the incretin effect with hormones, incretin changes. So very good. I usually take 3 medications for your diabetes, because 3 will come down to 1 medication. With the bypass, you come down to half medication. With the BPD, it's almost 0. And because of the pylorus, because of food control, the gastric bypass, you have the A1C which looks 5.5, looks great A1C. But if you look at the spikes and downs, they have significant spikes because of the early dumping, and then you have a significant lows, spikes, lows and downs. With the BPD-DS, it's more of a smooth curve because there's much more controlled release of the food particles and much more absorption. The A1C is probably will be 5.1 on this one, 4.7 on this one, but this is much more within the range with what I about. So the diabetes resolution is much better than the modified switch. It is still not covered by most insurance companies still because it's considered as the modified is not covered. The BPD is the gold standard, but modified is not covered. We fight the challenge, but it's working. So that's, and the biggest research, the global weight loss surgery, he has been a big proponent of modified switch 10, 15 years ago. He's been a BPD guy a long time. So that's why we see more concentrated interest in modified switch here in town. But yeah, as part of the Mercy, when it came in, I started doing the modified switch, and we're doing a good number of modified switches in our Mercy right now. So this is the PPD, in the modified switch, we do the division, but instead of, this is called a roux and Y configuration. Instead of that, we do a loop. So we go on and just loop it out. So the bile comes all the way up here and then goes down. So here the bile is coming here, the food is coming here, and then there's only 100 centimeters of common channel. In that case, we have a loop configuration. Loop configuration will give you around 250 centimeters of common channel. So bypass is much more, depending on the gut length. We only go with the common channel first. We go backwards. Yeah, this is back from 2007. Now it's 20 years now.
So, how long would you say each weight loss surgery takes on average?
The surgeries we do, this takes less than an hour. The gastric bypass takes between 2.5 hours. The modified switch as well on 2.5 hours. We do it robotic. The surgeries for the high school students itself. As a surgeon, I stand up and operate for, depending on surgeries, an hour to 2 hours, 3 hours, sometimes 7 hours. I don't want to do the cardiac surgery. I don't want to do cardiac surgery like you thought. A neurosurgeon especially. A transplant and all stairs, they can stand up to 12 hours, 14 hours. I can't do that. So that's why I said not to do the surgery. When I want to grow up, I want to be a cardiologist and then a cardiac surgeon. I want to be a pediatric cardiac surgeon when I want to grow up. Once I do the surgery, once I went into cardiac surgery, I'm not like the lifestyle. That's not for me. So I like this fun laparoscopic surgeries. All right. Anything else?
There's a new index that people are saying may be more informative about waist circumference upon height.
Yeah. I don't know. The body mass index by itself is not the perfect it is a good tool across the population studies, but population studies is better. The problem with the weight circumferences, it's more of the patients who have to come in the hospital, a doctor visit has to do their weight circumference. That is more important for the central obesity itself. But if you look at again women who are what we call peripheral obesity, especially Hispanic women, you see them that big, they're hefty, but they don't have much weight in the abdomen. So for them it's different. So we don't have a perfect tool. I do agree that it's coming up. It's a combination of multiple factors. So when I see the patients also, I tell them, when they have what we call a peripheral obesity, that's why I like the word use peripheral obesity, which is not centered in the abdomen. They do have less risk of metabolic complications from the obesity itself. So they might be BMI 45, 50, and then you see their A1C like 5, their cholesterol like less than 100. You'll be surprised how they are. Their fat deposition is not in the central fat, it's more peripheral fat. That's not affecting the metabolic pathways itself. So yeah, we still don't have a perfect one. But this is good enough general population study parameter.
Thank you, Pradeep. That was an excellent presentation. Dr. Pradeep Palani is a bariatric surgeon. He's practicing at Mercy the last 5 years? 3 years. Yep. So, so we didn't get a proper introduction to our group. So I'm Raj Dondeli. I have my colleagues here, Pradeep Palati, Samir Wadle, and Nirmal Kalambi, and another psychiatrist is going to come. We represent the group of physicians of Indian origin. Our chapter is called the Northwest Arkansas American Association of Physicians of Indian Origin. Our goal has been to raise awareness, create education, provide feedback to the community about the health issues that we all face. And this is the second of our series we did last year, and this is the second of the series. And hopefully we get you guys some information that's beneficial and helps you to make a conscious effort of taking care of your health in a better way. So thank you, Pradeep, and thanks for your time. If you have any questions, you want to take his consultation, he's at Mercy Bariatric Center. Feel free to reach out to him by his office. So the next, Samir Wadle, Nirmal Kalambi, doctor, he is a urologist. He has been practicing urology for the last 20 years. And he is in Northwest Medical Center. He is expertise in robotics, robotic urology, a lot of male and female urological procedures. So he's going to talk about this.
Thank you. Can you all hear me? Yes. Okay, I'm not going to use this. I'm Dr. Nirmal Kalambi. I'm a urologist. And we're going to have a little fun today because we have a young audience. I'm very proud of my heritage. My mom and dad was the first Indian in Northwest Arkansas. That's them. I keep that on my phone. The reason why I have that is she didn't know it, but she was pregnant with me in that baby. They came here in 1966, and it's really my honor to be here. They started the Friends of India Society. I joined the op to make a difference for all of you that are here. So first of all, I want to let you know, by show of hands, who is wanting to go to med school? Very good. Okay. So, just like my father did for me, I would love, and I know Dr. Dondetti and my colleagues would love to have, be mentors to you for the next generation of Indians in Northwest Arkansas. We appreciate what you do. It's a hard way to go, but we're here to help. So, any of you all need to ask questions, get information about what it takes to be a doctor, please don't hesitate to call any one of us. We will all help you. Our organization is here to help, okay? All right. Study hard. That's the key, right? So I'm a urologist. I'm in private practice. What that means is I'm not hired by a hospital, Mercy Hospital, Northwest, or Washington Regional. I'm actually on staff at every one of them. And there are many pluses and minuses to all that. What I like about it is my independence. Unfortunately, I've been on call for the last 7 days, so I've answered calls in every hospital, including one from Clarksdale, Arkansas. So that's tough. But it also allows me to go to any hospital and practice and do surgery. A urologist is a surgical subspecialty that does surgery on the kidneys, the tubes that drain the kidney, the bladder, kidney stone disease, all cancers of all those organs. And we were the first to introduce robotic surgery, okay? So Da Vinci robotic, I don't know if any of you all show hands. Have y'all ever heard of robotic surgery? Who thinks that the robotic surgery means that a robot is doing the surgery? Good. So we do the surgery, like Pradeep said earlier, but we're at a module. It's a laparoscopic procedure where we put instruments in, and then we control the modules, and off-site, and eventually that will be the case, but in the same operating room, we do surgery. So I do a ton of robotic surgery for prostate cancer, kidney cancer, and then I do a lot of surgeries for stone disease, kidney stones where you can bust them up minimally invasively, and then go into the kidneys themselves to take care of stones. And there's just too numerous to count various surgeries. I enjoy it as a surgical subspecialty because I could be doing something as major as cancer surgery and then go and do something for a lifestyle change, which leads me to sort of my presentation, okay? So having said all of those complex words and complex surgeries we do, I want to focus on several things. And, I'm talking about male and female health. Okay. So I'm what they call a surgeon of excellence, was awarded that in neuromodulation. Does anybody know what neuromodulation means? Does anybody know what neuro means? Brain, okay. What does modulation mean? That's it. So in certain situations, that's it, Chris up there. In certain situations, women especially, but men as well, develop over time as we get older, difficulty with urinary frequency, urinary urgency, which is frequent urination that I need to go to the bathroom, and sometimes leakage, unfortunately. And it requires people to wear pads and other protective garments so that they're not leaking, okay? And that's urine and stool. We have conventionally used medicines to treat that, okay? But in a large subset of population, that does not work, okay? So what we have to do is stimulate a particular nerve, whether it's a new one that I just got, I was the first in the country, 20 in the country about a month ago to be trained in this, where we stimulate the tibial nerve with a little battery. I'm introducing that. I'll be the first one to do that in Northwest Arkansas. But conventionally, we've been using a nerve that comes out of the sacral area. You know what a sacral means? Go ahead.
So would that be more for the elderly who are losing control of their systems, or would that be for?
I've done as young as 30 and as old as 80. You're right. And there are various reasons. There are medical reasons why somebody can develop incontinence early, too. It's a good question, though. But the main thing is we try medicines and conservative therapy first. I have a pelvic health clinic that's associated with my office, and I do lots of pelvic or physical therapy, as well as medicines and other modalities before we go to surgery. But when we go to surgery, you can see all these statistics. I'm not going to bore you. But what I do is I go into the back, and I stimulate a nerve that is actually a peripheral nerve coming out of the sacrum. And we know that by stimulating that nerve, it creates a system of fibers and let's call it signals to the brain that allows the bladder to be modulated. And then we can get people dry and help them flush. And that's just the basics.
It's a cake.
And so that's one thing I do, okay? And I enjoy it. It takes me about 3 to 5 minutes to put a lead in, and about 10 minutes to put a battery. They can last for 10 to 15 years. So this really impacts the quality of life of women and men, because they don't have to wear protective garments. They can go out and do whatever. I also am an expert in female incontinence, so women that leak with coughing, sneezing, lifting, trampoline, I can do a 5-minute operation and get them dry. And that's a really good part. I mean, in this all the cancer cures, the quality of life really is important because a lot of people don't go for that initially. They think they need to live with it. It's part of aging. And it's part of my education for folks to make sure that that is not something that they have to live with. Okay? So then all right, fine. So that's one thing. And then there'll be another slide here in another. The other thing that I'm a surgeon on is prostate surgery. I talked about robotics and cancer surgery, right? Well, there are other surgery we do because as men get older, that organ, which is very important in fertility, you know, having kids, it gets larger and it constricts the urine stream and causes issues. And there's a particular surgery, again, I'm a surgeon of excellence on, called green light laser. Have any of y'all studied lasers in high school? When you study the lasers, you'll understand that certain wavelengths of lasers treat certain things in certain ways. Certain lasers can go through wood, certain lasers can go through soft tissue, certain lasers can go through steel. This particular laser, which is a green light laser, the wavelength and the frequency of it and the properties of it, it absorbs hemoglobin. So I can do a laser of the prostate and have very little bleeding. In fact, I can do it on people with blood thinners, which is, as a surgeon, very scary because we don't like to operate on people with blood thinners because people can bleed to death, right? So that's where this laser is good. I don't know. So this is the nerve to go in and then I stimulate. So we just talked about it. And then this is the new one that I just got trained in. I was flown to, I can't remember where, but anyway, some city, and I was among 20 surgeons to be trained and certified in this. And obviously there's going to be 200 surgeons in the nation that will do it. I was very honored to be invited to do this. But this is pretty cool because no leads, no back. We just click this little device and it stimulates the tibial artery, or tibial nerve rather than artery, and similar. And for young, I'm going to actually do a couple of young people because this will be better for them because this won't be as painful. Not that it's very painful.
It's a cake.
So that green light laser we're talking about, that I can do a surgery, they go home the same day, and then they're able to avoid it. Okay? The last thing that I want to talk about is something that you guys, I'll just touch on. Okay? As men get older, men have difficulty with getting erections. Does anybody know what an erection is? Okay. So I can do a lot of things for that. okay? We treat it with medicines and those things. It's a natural part of getting older, but people don't have to do it. One of the things I want to talk about is when medicines don't work, I can do a surgery and maintain that. So that's the last thing that I will tell you that I was prepared to talk about. So these are all lifestyle events and lifestyle things that I do. One of the small about things that I do in addition to all of the cancer surgery, like Pradeep said, every day I do something different, and I love it. I have a large clinic practice in which I do a lot of procedures. What attracted me was the different gadgets that are there in urology and the lifestyle. Just like him, when I was in residency and I was doing my general surgery, which I had to do before I specialized, I was actually recruited to be a cardiac surgeon within the program. I looked at it as well and decided that's not for me. Because as Indians, we know family is very important, and lifestyle is very important, and having that balance is important. Just like him, I didn't want that lifestyle. So I love my specialty and all the things I do. So, yeah, who knows? Maybe one of you all can come and take over my practice. It's a 65-year-old private practice. So, any questions, just come and join us. Go ahead. So, so are you the one who wants to be a neurosurgeon? Okay. So, so central nervous system, peripheral nervous system. The central nervous system is the brain and the spinal cord. Okay? Peripheral nervous system are the nerves out here, and the nerves that come from the cord. What I have to do to modulate is I'm looking at the cord, but at the very end of the cord, there's peripheral nerves that come right out of those bones. That's what I'm concentrating on. Exactly right. Good question. Any other questions? Yes, sir.
You said you mentioned about cancers, right? Do we have, with all the latest innovations and everything, do we have any one specific, I've been reading about a blood test that can cover your, any future cancers and all. Do we have anything like that we can talk to?
Yeah, I can talk about it. Yeah. So, I cover all cancers in my system. Kidney cancer, bladder cancer, prostate cancer, testicular cancer. From 18 to 35, very young group, that's when testicular cancer happens. So we always tell people, make sure if there's any abnormalities in the testis, to go to your doctor. That's very important. The good news is that is the most curable cancer of all. It can be the worst stage disease. Has anybody heard of the biker Armstrong? Lance Armstrong, sorry. He's Armstrong was a famous biker, and he had metastatic testicular cancer. Obviously, he's still alive today, which is great. Now, kidney cancer, bladder cancer, all that. Let me just give you one thing. Smoking is associated with every genital urinary malignancy, so don't use nicotine. Don't use smoking. Put us out of business, because I will tell you the vast majority of cancers are associated with nicotine and excessive alcohol use. And now we know, like the doctor said earlier, obesity and fat has association with cancer. One thing that we should talk about is PSA, prostate-specific antigen. Every week, I do a robotic prostatectomy on average, at least one. So I go in and I remove the prostate, the center vessels, and I put the bladder back together in the urethra. Prostate cancer. It's the second leading cause of cancer among men after lung cancer. I'm sorry, it's the second leading cause of death among men. I think I said that. And very, very prevalent. Primary care doctors will say, well, everybody will get prostate cancer. And to some extent, that's true. If you are 80, you have an 80% chance of having prostate cancer. However, it is the second leading cause of death. Now, as a society in America, cancer is a bad word. There are many more people that die of cardiovascular diseases, heart attacks, strokes, all of that, than cancer combined. But in order to stop that, we have to make dietary changes that we just don't want to do. So we don't get as much funding on that. We get the funding on the cancer, and that's really not altogether a leading cause of death. It's interesting if you really look at the statistics. Diabetes, hypertension, cardiovascular, that's the vast majority cause of death, okay? But prostate cancer can kill, especially if it's early. So we advocate between the ages of 50 and 64 getting a simple blood test called prostate-specific antigen. And depending on what that number is, we as a urologist and the cancer experts in the surgical cancer experts will discuss options. That could include a biopsy. That could include an MRI. Now, we have many studies showing that there are certain genetic properties or methylation. I can go in and talk to you about these genetics, but it's not really important. But these tests can screen also to determine how aggressive a cancer can be if you're diagnosed with prostate cancer, or whether you are at risk for particular prostate cancer. Breast cancer has had this for quite some time, and breast cancer and prostate cancer are very, very similar in how the natural history goes, okay? So you all have heard of Coleman, Race for the Cure, right? Almost with testicular cancer. I'm the medical director for the Arkansas Prostate Cancer Foundation, and I'm on the board of the Arkansas Prostate Cancer Foundation. I developed and host Pig Skins and Prostates, which is an entity that we do at Topgolf every year to promote awareness and create funding to help folks, especially those that do not have the means to be able to be educated about prostate cancer and even actually have surgery. I've done surgery, obviously, for free on patients through this organization. Okay? So hopefully that answers your question. There are blood tests that one can get. We don't generally want a shotgun blood test. It's not what we call efficient use of funds for that. But we can certainly target certain individuals. I hope I answered your question.
Something we need to ask our physician, like our general.
Primary care doctors, they're the gatekeepers. They are well aware of, now colonoscopy stage of 45 instead of 50 or 40, maybe, I don't know, 45. PSA, mammograms for women. I think somebody's going to be doing a talk on that here shortly. But those are all very important. The primary care doctor generally is the one that does it, and if there's an abnormality, they send them to a surgical subspecialist. Thank you. Yes, absolutely.
So what I want to ask is, a common person wants to know would be the diets that will prevent them from getting kidney stones. That's a common thing we see in our population. And then what are the specific things they need to look for if they're worried about prostate or prostate cancer or enlarged prostate?
Two great questions. On the stone question, I always counsel my patients, and honestly, this is probably good in health. Is that too loud? Drink 6 to 8 glasses of water a day. Add lemon to your water. We know that at the kidney level, citrate can inhibit stones. Okay? And then do not add, and as Indians we don't, but do not add added salt to your diet. At the kidney level, sodium and calcium exchange at a certain tubule and puts calcium in the kidney collecting system. And then if there's oxalate there, then it forms a stone. Lastly, I'd say Cokes and soft drinks and anything high in oxalate, you may want to limit, especially if you're a stone former. If you form stones and require surgery, 2 times in a year and pass stones multiple times per year, I tend to send those patients to a nephrologist who is a medical doctor of the kidney, where they do what we call a stone metabolic workup. They actually check the urine for 24 hours, look at the metabolites, and sometimes they can direct therapy with medicines to prevent those stones. The second question is very good. The American Heart Association, in terms of their diet, has modified their pyramid. People probably have seen, there used to be a pyramid, and you may have to help me on this, that used to be top-down base. It's kind of inverted now. So we want to have more protein, less carbs. We call it a heart-healthy diet. Prostate cancer, we know a couple things. Number one, it's associated with smoking. Number two, high fatty diets, which is probably why we don't see as many patients with prostate cancer that are Indian. Western diet is not necessarily good for prostate cancer. And then, zinc, lycopenes, these types of things can be utilized to help prevent prostate cancer as well. Prostate cancer, unfortunately, early on, has no symptoms. So we really rely on a good exam, a good history, and the blood test. And I would also say to my primary care friends that if a person is not responding to medicines for urinary flow, that could be a bad sign because prostate cancer doesn't respond to those. So we got to think about that because they lack the smooth muscle. The other thing, one caveat on PSA too is when prostate cancer is really bad, aggressive, it stops making PSA. I'll give you a little short story. I had a guy, unfortunately, that came in 1 month ago, and I was talking to him. He had severe lower urinary tract symptoms, meaning frequency, weak stream, all those things. And he had a family history of prostate cancer. His primary care doctor did not do a prostate exam because he checked the PSA. The PSA was 0.7. They reviewed it, was 1, it was okay. I saw him, I did a prostate exam, I knew he had cancer. I did a biopsy on him with a normal PSA. Every single core or biopsy was positive for Gleason 9, which is the worst you could have. I did imaging on him, I did a PET scan, widely metastatic to his bone. He's 52. That's the gentleman that will likely die within the next 7 years of prostate cancer. And that's why it's the second leading cause of cancer death among men. What's the first leading cause of cancer death among men or women? Correct. What's the third? Nope. Nope. That's the second. Colon. Skin is the most common cancer, period. There's not one. Skin cancer has different types of those. So those are little stats that probably, just to have there. But that's why it's important for screening. Prostate cancer, right? Colon cancer, right? Lung cancer. I think I took up too much of your time. Thank you. Like I said, we're here for you guys, young people, right?
So much. I appreciate your time and feel free to reach out to Dr. Columbia's office if you hopefully don't need his help in any time. But if you do, he's there.
I went to Little, UAMS. I went to med school there, and I went to Ole Miss for my residency, Jackson.
We can take a few minutes break in between while you're focusing on changing the laptop in a few minutes. There are snacks in the back. Please feel free to grab some.
I got prints in my.
No, that's why after Yes. Camp means activities. Like you. Last year, we gave but that was feedback. We need to consider.
Talking on these 5 topics, and then there are questions.
Yeah. Yeah. Submit it before.
Last thing, questions at the end. We'll have more things to know.
Hi everyone. Can we, I'd request all of you to come back. We can start the next session. Please, let's get seated. And Dr. Wagle will start his session.
Hello. Yeah, so good morning everybody, and thank you for inviting us to share our thoughts about the current medical advances and what we know about our specialties. So I'm a neonatologist, so neo means new and natal means birth. So I'm a specialist of a newborn. And unlike Dr. Kalambi, I'm an employed physician. And most of the doctors who have their patients only in the hospital are typically employed by hospitals. So our patients are not in the clinic. So like Dr. Kalambi, Dr. Dondeti, they have a clinic which is separate from the hospital. And so those doctors are more likely to be in private practice. So we are like shift workers. We start our shifts in the 7 in the morning and we finish next day 7 o'clock. So I'm like an intensivist amongst all the kind of physicians that you remember they are being called specialists. So I'm not an obstetrician. The obstetrician is the one who delivers babies, but I take care of babies who are sicker. And often sick babies are delivered from a pregnancy that's very high risk. So I thought of just sharing some of my thoughts about how to actually accomplish a healthy outcome of the pregnancy. And so the healthy pregnancy is truly to prevent complications of pregnancy that we consider critical, such as premature birth of a baby, or having a condition called preeclampsia, where the mom's blood pressure gets so high that she may actually have a stroke almost from a hypertensive crisis. So the other thing is to also promote normal weight gain in the mother, promote the baby's well-being inside the mother, and finally, delivery, especially we preferred a vaginal birth at term gestation. And we promote breastfeeding because breast milk seems to have a lifelong effect on the baby's metabolic condition. So we divide the pregnancy into certain periods, and the first period is called preconception, and this is the time when the baby is initially being made, and the mother's lifestyle can have tremendous impact on the baby's development. And so we want every mother to plan a pregnancy and not just be casual about it, because that can have significant impact. So the things to do is important is to bring the lifestyle change. Main thing is quitting smoking, quitting alcohol. Second thing is to make sure if you truly have chronic, yes.
Sorry, I didn't mean to interrupt. But so does sorry, I forgot the name of this series, but does it happen as soon as the sperm is egg and eat, or does that happen like 2 weeks after?
No, this is preconception. The baby is not even conceived yet. This is before you end up having the sperm and the egg turn into an embryo. So, and that's because if you learn through your genetics, it is called epigenetic changes. So the mother's environment of her own health impacts the baby's and her eggs and the embryo's genetic expression. And so we would like mom to be in the best of the health, and that's what we call, if she has any chronic conditions, especially thyroid, blood pressure issues, diabetes, to be got the medication managed well so that she can be in the best of health when she's trying to conceive. Some of the medication she's on could be also dangerous to the growing embryo. We call that teratogenic drugs, and some of these drugs can be prescribed early on, but during pregnancy they are dangerous. And the drug that is something that we use for acne, it's called isotretinoin. That's one of the worst drugs to be on if you're going to conceive. So those drugs need to be stopped and changed to a safer alternatives. We would also recommend mothers and fathers to undergo what we call genetic screening for conditions that can result in an affected baby, and those conditions could be something like we call cystic fibrosis. Have you heard of that condition before? Yes. So it's an autosomal recessive condition, which means both mother and the father are carriers, and when they have a baby, it ends up having both the mutated genes getting together to give rise to a cystic fibrosis. So it's good to know if your carrier status, so in case you do, then your obstetrician can be more vigilant to see if the baby is affected or not. So, and the fragile X, has somebody heard of this condition, fragile X? It's one of the common cause for autism. So it's good for our moms and dads to know if they ever have a carrier status for this situation. So the next step is, now that the baby is conceived, is the first trimester. This is the first 12 weeks of pregnancy. And the important thing is to truly find your obstetrician and start what we call prenatal care. This is so important because it allows for accurate dating of the pregnancy, so the mother would know exactly what's the due date is, and that allows us to monitor the pregnancy more accurately, especially for fetal growth and weight gain. We also, during this first visit in the first trimester, kind of assess the mom's vaccination status against conditions such as rubella, chickenpox, which is varicella, Tdap, which is the main vaccine for pertussis and the tetanus, the influenza and COVID-19. Those vaccines are definitely helpful to prevent the baby from catching it, as well as if the mother acquires flu or COVID during pregnancy, the babies can be delivered prematurely. So the other thing we do is to check the mother's status for lots of prenatal infections that mom can pass on to the babies, which is we call mainly the hepatitis B and C, HIV, syphilis. The other viruses is cytomegalovirus and a herpes simplex virus. So those are, when passed during the earlier gestations, the babies can be severely affected. The other thing that we ought to do is to know your blood type and the antibody screen, because those can create severe anemia in the baby. We also recommend that the mom starts to change her diet to mostly a Mediterranean style diet, which is plant-based diet with proteins can also be procured from poultry and fish, but limit the red meat, and have lots of fruits, vegetables, we call lentils, nuts. So those are kind of very much similar to Indian diet, except our diet has lots of starch in it. We truly need the whole foods other test that we also do on mothers at this first trimester is called harmony screen. So this is one of the newer advance in the science where a baby's DNA, which is soluble DNA, is actually circulating in the mother's blood, and that DNA can be actually harvested from the mother's blood and analyzed for conditions such as Down syndrome. So those are called aneuploidy screen, where you could diagnose Down syndrome in mother's blood by checking the baby's fetal DNA. So this is a very tremendous advance that has happened, and we screen for 4 conditions that is called trisomy 21, 13, 18 and Turner syndrome. So those are the 4 important test conditions you can diagnose with trisomy screening. And then secondly, you would, yes.
Just to clarify, 1521 is the where there's 3 chromosomes on the 21st pair, right? Hi.
Yeah.
So trisomy 21 is where just to clarify, it's where there's 3 pairs there are 3 pairs of chromosomes on.
That's 3 chromosomes.
Three
So
chromosomes.
typically, you have a 1 pair from the mother, the 1 pair from the father for each chromosome, and we have 23 pairs.
Where does the extra pair come from?
The extra pair come from either could be mom or the dad. So we don't know who is responsible, but often we believe it could be mom in certain cases, sometimes it can be even dad.
Okay, and then is there a disease that correlates with that trisomy 21?
The trisomy 21 is a person who has Down syndrome.
Down syndrome. Okay.
And Down syndrome affects every organ in the person's body.
And then trisomy 18, what would that be?
That could be another similar condition, but it's much more life limiting. The Down syndrome people have a fairly normal life expectancy, maybe lesser, or in 60s they can live up to, but the trisomy 18 and 13, they don't live beyond teens, and 13 doesn't even live beyond first year.
Oh.
But over the last 5 years, as parents have insisted on saving these babies, they have been living longer and longer. All of them have severe defects of major organs. Especially for trisomy 18, it's the heart has multiple holes, and most parents were not ready to put them through major surgeries, but now they are willing to do that. So we don't anymore tell the families to take the babies home and let them pass away. We now intervene for almost all of those conditions, and these babies have been living, but their developmental age is no more than 1 year.
Okay.
So a child cannot progress to trisomy 13 or 18 beyond a year of age.
Okay, and then another question, you mentioned Turner syndrome. Is that a trisomy or is that a loss of a chromosome on any of the
It's Turner syndrome where the X chromosome pair is just 1 chromosome.
Oh, and there's no Y chromosome.
There is not even X chromosome. So usually Turner syndromes are girls, and they lack 1 X chromosome.
They lack 1 X chromosome.
That's
And
right.
the X chromosome is from the mother? Or is it?
I don't know in that level, but one of the X chromosome is missing.
Okay, it's missing. Okay.
Yeah, and most of the women with Turner syndrome will be only recognized because they are short stature and their ovaries are not fully developed, so they will not be able to have what we call menstrual cycles.
Okay.
So this is the gestation that, having seen your OB early on, will let you know if you carry also twins. So that's why it's so important that as soon as you miss your cycle, the mother finds an obstetrician, starts the prenatal care, watches her diet, quits smoking, checks her blood medications with teratogenic potentials. The next phase is the 2nd and the 3rd trimester. This is where the obstetrician will also assign a high-risk status to the mother's pregnancy and will make the mother visit more often to keep a close watch on the baby's growth. The main thing we have to remember in terms of maternal diet, this is the time that we do not want mom to be eating, especially the undercooked meat, because of the concern for a parasitic condition called toxoplasmosis that can come through the meat. Also avoid fish with high mercury content such as shark, king mackerels. The unpasteurized dairy is such as soft cheese. Those are, they can have an infection called listeria. So those can be passed on to the baby. We don't want her to get cold dairy meats, raw shellfish like oysters. So those are important. And anytime you eat fruits and vegetables, that you clean them thoroughly with, wash them properly. We talked about the Mediterranean diet. The supplements that we would like every mother to be on is the prenatal vitamins with iron, calcium, fish oil because it's important for the baby's brain growth, and the probiotics because it allows for healthy bacteria to be in your intestines and in the vaginal area. We also want mom to be very watchful of how much weight gain she's going through. If you are a thinner person with low BMI, you are allowed to have more weight gain. But if you are an obese person, then the excessive weight gain translates into problems such as diabetes and hypertension. It's good to stay active during pregnancy, yes. The baby is not born yet.
No. I'm sorry. I thought you meant when the baby is born, it will have these different. So I thought that when we were talking about when the baby is born, it will have all these defects. Like you were talking about the tyrosine and the Down syndrome. So when the baby is born.
No, this is basically we are talking about during the second and third trimester as the mother is gaining lots of weight. She has to be watchful because if she gains excessive weight, it translates into making her prone for blood pressure and diabetes. No, maybe it's my fault. I didn't explain what are the trimesters. The human pregnancy, do you know what's the duration of a human pregnancy? Yeah, so roughly we call it 40 weeks. Yeah, and the first 12 weeks is the first trimester. The 12 to 24 weeks is the second trimester. And after 24 weeks comes the third trimester. So those, and then we call it, now the new thing is that after the delivery, the next trimester is also called fourth trimester, which is postpartum period in the mother's life. Yeah. So the other thing that the mother can also discuss with her obstetrician is what we call aspirin prophylaxis, which is important for mother to discuss and see if she qualifies for the aspirin treatment, because that helps to prevent a severe condition as we talked about called preeclampsia. This is where the mother ends up with a swelling of the feet, blood pressure problems, and having problems with the liver functioning called HELP syndrome, and ultimately ends up with a premature baby. And so the aspirin prophylaxis can help with this condition. The other thing that we talked about is the parasitic infection in a baby called toxoplasmosis that comes from a cat feces. Sometimes when moms have a cat at home, they have to be very careful to change, not be using to change the litter box, because that can create the infection being transmitted to her, and it looks like a simple flu disease, but it could be actually a toxoplasma infection in the mother, and that can go to the baby. Also, it can come from gardening, especially because of the soil can have these cysts of toxoplasma. and so she needs to make sure if she's going to be working in the garden, she uses gloves. The other important symptoms she needs to be aware of are the called red flag symptoms. Those are where she ends up all of a sudden starting to have vaginal bleeding, a leakage of fluid, reduced fetal movements. The babies after about 12 weeks starts to move inside the mother in the uterus, and it's much more apparent after 20 weeks. And so if the baby stops moving suddenly, it's a sign of distress in the newborn. Having an abdominal pain, something like menstrual cramps, is alert or a beginning of a preterm labor. And she needs to go to the nearest hospital which has a level 3 NICU. So the neonatal care are divided into 3 levels, like level 1, 2 and 3. And then level 3 NICU is the highest NICU that can accommodate or manage babies who are extremely premature. So the mother should try to go to one of these hospitals where the level 3 NICU available. The other thing important mom has to go through is screen for gestational diabetes. The diabetes is, as we are all experiencing, the mothers are marrying late, they are having children late, and they are going through the normal stress of pregnancy, which is making them prone for diabetes. And now we have known that diabetes is an important even contributor to babies with children having autism in future. So we have to try to prevent the diabetes if possible, but if not, at least control it well so that babies don't overgrow. When mom has diabetes, the babies get excessively overweight and can't come out vaginally, often end up with a C-section, and sometimes these babies can even get stuck even to come out of C-section and can get severely brain damaged or have fractures of the clavicles and humerus. So it's a very serious situation, have what we call fetal macrosomia. The other thing that we do is screen for cervical length, and that allows us to identify moms who are at risk for preterm birth. We look for ultrasound for fetal anomalies that could be like congenital heart defects. We look for fetal growth and fetal presentation. So this is the time that some moms will be diagnosed with breech presentation, and these babies can be turned with the head down if we knew it ahead of time so that we can avoid a C-section. We look for a bacterial colonization in the mother called group B strep, and that allows us to treat the mother during labor. This is the time that moms typically pass the infection to the baby, and we can actually have less infection getting to the baby that way. And then there is a condition called cytomegalovirus infection. So this is one of the most common infections that gives rise to deafness in kids. And the infection happens to be transmitted from the mother to the baby during fetal stage of life. And the main person who is infecting the mother is often her own child who is more than few years old, especially the one who goes to preschool or early elementary school, where this infection is very common amongst children. So it's typically, it could be even a mother who has exposure to small children, like a teacher. So she works in an elementary school, gets exposed to a child with CMV infection, and then she passes this infection to her own baby during pregnancy. And that ends up creating a permanent hearing loss in a newborn being and deafness. So we want the mother to be very careful and not get exposed to the baby's saliva. So we don't want her to kiss her own child during that pregnancy period on the especially mouth. Sharing the food or utensils, often in Indian culture we finish the food that's left over in the baby's or your child's plate, or if the child is a bit younger, she's on a pacifier, then if the pacifier falls down, often some mothers will put it in their mouth to clean it. So this is a very common cultural practice, and it can result into mom getting infected and passing the infection to the baby. So finally, we end up with a delivery time and labor, where the baby gets monitored, and during this time we monitor to make sure the baby is tolerating labor well. If the baby won't tolerate uterine contractions, then often it ends up into a C-section delivery. The new thing that we have to remember that now it's recommended that we delay clamping of the umbilical cord at least 60 seconds to allow for a transfusion to happen from a placenta to the baby, and that allows for less incidence of anemia in the newborn. We all recommend as soon as the baby is born to put the baby next to the mom's bare skin so that it allows for better temperature control, glucose regulation, as well as promotes breastfeeding success. We don't routinely perform procedures such as episiotomies. That used to be the case before. And right from the beginning, within first 6 hours, we do want baby to experience more breastfeeding opportunities. And as we discussed, this is the postpartum period that the baby is delivered, and we recommend the moms to go and see the OB after delivery instead of 6 weeks at 3 weeks, to be more getting screened for postpartum depression, especially also making sure their blood pressure control is still normal, and then making sure they get advice regarding the contraception so that we space the pregnancies at least for 18-month interval. So those are very important guidance. And then get the help from the lactation consultants to be successfully breastfeeding for first 2 years of life. And for newborn, the practices that we want every mom to be aware of is we call ABC of safe sleep, where every baby needs to be alone in the bed with no bumpers and pillows and blankets. It should be always be sleeping on the back and in the crib with fitted sheets. So that's what is called a safe sleep, and that has been able to decrease the incidence of what we call SIDS, or sudden infant death syndrome. We want to make sure that mom tries to breastfeed exclusively, and there is no particular diet that we recommend during breastfeeding. But the diet should be as she's used to, or healthy in overall aspects, but there is no special diet. We send 3 screens in every newborn delivered. The one is called a screen for metabolic screen, it's called PKU in a typical common term. We check for baby's hearing, and we also check for congenital cyanotic heart defect with a pulse oximetry screening. And then every baby gets vitamin K injection to prevent intracranial bleeding, and then erythromycin prophylaxis to prevent eye infection. So those are the important milestones that every mother experiences throughout her pregnancy till you deliver a baby and go home. So those are kind of important guidelines that I have put forward. Do you guys have any questions in particular? Yes.
So you mentioned a lot of tests to do with the second and the trimester.
Yes.
Is this like normal, like everybody
everybody gets. Everybody should get tested, but because of the, we have a little individual bias. If you come from a well-to-do family, you are in a very close relationship, you think you don't have multiple partners, then we tend to feel like, we don't want to expose so many tests on this mom. But the general rule is we do not want to use our biases to test, because even in a good family you could have issues, So we don't recommend using the affluence, or you could just say a race-based approach to screen for infections. We want to check, because finally it's the babies who is going to get affected.
So in US, like when somebody is pregnant, they go through all of this test.
All of them, the hepatitis screen, B and C, the GC, which is gonococcal, chlamydia, they get HIV, syphilis, and then the rubella immunity gets checked. We do want to check for herpes and CMV, because herpes is the very serious complications of a newborn, but the cytomegalovirus is the one that leads to deafness, and it's the most common cause, and so it's good for us to know if the mother is already has CMV infection in the past, because her chance of catching it is less. But if she's negative, she's very high risk to acquiring it during pregnancy and giving it to her baby. So that's the mother that you want to be advising her about being careful to be exposed to saliva. Yeah. Yes.
They found something like a Down syndrome in the new baby infant. How they will treat or what they will do.
If the person has baby is found to have Down syndrome.
Down syndrome or any other chromosome defect, you said something that we have 6 missing or something. So what they will do?
Yeah, well, if your baby has a Down syndrome, typically, at least in the United States, it's not considered a lethal condition. And so there is, typically we would allow the pregnancy to continue. But if you are in countries like India or other, there may be availability if you are under 20 weeks to terminate the pregnancy. For 13 and 18, because they are considered fairly lethal, because as I said, these children don't live beyond few years, and they don't develop more than 1 year in their ability to develop. So the quality of life obviously is not there, but families who have experienced these children have found meaningful life in these children as well. So nowadays, we don't recommend that they terminate, but if the families want it done, then it's possible. But since many states have limitations on abortions, it's not going to be easy in states like Arkansas or Texas, where there is no way you can terminate a pregnancy after 6 weeks.
But before 6 weeks, are they allowed to do that?
Before 6 weeks will be so, that will be very early. There is no test to diagnose Down syndrome before 6 weeks. Yeah, usually the earliest test is in the first trimester. I talked about the harmony test. So that allows you to be able to diagnose it, but that test is done typically at 8 to 10 weeks. Yeah, because of the anti-abortion movement, it's going to be only available in states where the abortions are feasible. I think the states, Kansas is, and I think Colorado, and there are certain states, California, they will have it. But it is a challenge.
So just like suppose suppose if they moved out in US, the doctor, the doctor advised to go to India or something for.
Yeah, you can go to India and have it terminated, but yeah, because there are babies who are born with severe malformations, like severe defects in the bodies, and there is no way to have these babies be terminated, and mom will be forced to keep the pregnancy go on until delivery, and then the baby won't make it.
How about the autism syndrome? If they found it in the before born autism, they found it anything autism, they will be able to teach during the pregnancy.
Not for autism.
So they have to.
Yeah, they will have to continue to have the baby. Yeah, there are not good tests right now. There are very few genetic tests that are positive for 100% autism. So it's going to be tough to agree to terminate a pregnancy just because the baby has a gene. Because even they have found, even though autism is much more genetic condition, even amongst the identical twins, if one child has autism, the other child may not have autism. So it's not fully genetically expressed. It's a combination of genetics and the environment. Yeah.
Thank you very much, doctor.
Well, thank you, everybody. Yeah, go ahead.
Like, why is jaundice so common is it common for Indian diaspora for newborn babies?
The jaundice? Yeah, the newborn jaundice is a very common phenomena with every baby. I think amongst Asians, especially our race and even from East Asia, like Chinese, Japanese, we do have a higher tendency for our babies to have jaundice, but it's not in a very severe grade. So the severe jaundice is where the level is more than 25. That's rare no matter which race you look at. But levels up to 12 to 15 are pretty common in Asia. Yeah.
I have one last question. We have a lot of young crowd over here. Can you explain your journey, what it took for you to become a neonatologist, and just your experience, your lifestyle, what it means?
Oh, well, as I said, my lifestyle is kind of a little hard because when I'm on call, I need to be available to be in the hospital within 30 minutes of babies having to be delivered. So once the mother comes in a preterm labor, they will let me know, and then as soon as the mother is about to start to push, they will call me, and I'm usually be there within 10 minutes. But that's one thing, and since this is a kind of a shift duty, we take turns, and we can't always find somebody to take care of our shifts when there is a Diwali or festivals or my son's birthdays or ball game or anything. We just end up sacrificing lots of those holidays and family events to be able to pursue these specialties. So it's a challenge when you are in an intensivist profession. But my journey is like I studied in Mumbai, which is a highly popular city, and we competed pretty night and day to be in the first 100 students to get selected into the med school. And from there we ended up competing for residency positions. So from there I was a faculty at my own hospital for 2 years. From there I went to Australia, did my fellowship in neonatology. And then I came to US, did my residency and fellowship again at Children's Hospital, Philadelphia. And from there, I've been to Mississippi in the rural town. There are clinics called Federally Qualified Health Clinic, FQHC. So that's where I was sponsored for my green card. And from there, then I came and took this job for the last 25 years. I'm here now. So that's kind of in short my journey is you end up repeating some of your education in India here again. But the reason you got chosen to be here was because of your training in India in a way. So I think Indian physicians are well respected overall, as more compassionate, more empathetic, and very bright because we are all intelligent and very competitive students, right? Okay, any questions about babies? No, you didn't come up with any? Okay, all right,
Thank you.
thank you.
Hello. So next week we have Dr. Raman Shekhar. He is a psychiatrist here in Fayetteville. He's going to talk about drug awareness and other behavioral issues.
Thank you. So, a drug. What do you understand about drugging? What is drug? So, drugs are the substance that affect both your mind and your body. So it could be anything, which is in excess, we use, then it will impact that. And as you can see, that it causes psychological dependence and also some physiological dependence, which means that your body cannot want it, and that can lead to death. So I kind of focused on teens, so I can see that, why people use drugs. I mean, does it sound familiar? Yeah, to cool, peer pressure, relieve stress, sometimes, celebration. Yeah, so, that's how it kind of starts sometimes.
Perform better in exams.
Yeah, I mean, we see that sometimes, people are somehow having this conception that it increases the, cognitive enhancing. So that can lead to addiction too. So the risk factors, as you can see, who are the, what are the things that happen. Friends who use drugs most likely be absent in the school because they're busy with the recreational drugs. It happened. They can show aggression, defiance, and as Dr. Regular said, prenatal exposure of the drugs to the newborn can actually lead to adolescent use of drugs. So that's why parents have to be careful during pregnancy what they're doing and where they are, what they're doing. Yeah, some other issue, happen in the parenting, lack of monitoring, who they're hanging out with. As a teenager or, even mid-school kids nowadays getting exposed to drug use. Types of drug, I guess you guys have some idea. Stimulant, we call it uppers sometimes. And, they are like caffeine, amphetamine, bath salt. Have you guys heard about bath salt? Yeah, so speed, cocaine, those are kind of uppers. And downers are like slow down the brain and central nervous system. So alcohol, various kind, heroin, cannabis, sedative, some hallucinogens, LSD, ecstasy, magic mushroom. Yes. Yes, so steroids are kind of a special kind of drugs, I'm not kind of classifying here because, there are so many drugs, but yeah, we see people, young people, a lot of time, they go to the gym and they meet another friend or somebody said, oh yeah, if you want to be like, gain some muscle mass, try this, that's how they get addicted to that. And that's a very common thing happening in sports. And a lot of people get banned from the sports because of steroids. Okay, so a little bit more about alcohol, like what it does, and immediately like what it can cause, like after drinking and what actually happened. So the main issue that happened is that people has like a poor reaction time. That's why people get pulled over by the police for drunk driving because they have those slow reflexes. In higher dose, actually, person can die. Blackout. People say, "Oh, I had so much alcohol, and I don't know what happened." He's lucky. People can die from that excessive use of alcohol that can lead to death. Yes, it's a depressant. All right. So what happened? Alcohol use. Nobody see the bigger picture because it's hidden under our skull. Normal brain and comparing to the alcoholic brain. Look at that. It's worse than the Alzheimer's brain. That's alcoholic brain. Normal brain and the alcoholic. Also, alcohol can impact your liver. It causes a condition called fatty liver, so that's kind of a normal liver, nice color. And look at that fatty, pale, yellowish color liver. So it's happened, if someone drinking heavily and then they stop, the fatty liver will go away. It's a very common condition that we see people with fatty liver disease coming to the doctors and say, oh, I'm having some pain, because the liver become bigger and it has like a covering and it creates tension and that causes pain. But over the time, if they stop drinking, it will go away. Some more So as you can see that when liver swell, it's called hepatitis. It's alcoholic hepatitis, okay? So you heard about hepatitis A or hepatitis B, hepatitis C, but alcohol also can cause hepatitis. It's called alcoholic hepatitis. All right. That's kind of the progression of the alcohol use impact on the liver. This is the cirrhosis of liver. Look at that liver, how it kind of like a knotty and kind of shriveled because alcohol caused that. All right. Alcohol also can impact your heart. As you can see how the alcoholic heart looks, it gets bigger. I see a lot of patients coming to my hospital with alcohol-related heart problem. They get bigger heart. It's called dilated cardiomyopathy. Their heart actually gets bigger and it cannot pump properly, and they develop heart failure. And unfortunately, eventually they die. So 32% of the fatal car crash involved intoxicated driver. And any DWI, as you can see, you are not going to be eligible for FAFSA if you're applying for college. So it's kind of a very bad thing to have. I mean, any profession, any good profession, if you want to go in the future, they will do background check. And if you have a DWI or DUI, it will be really not a good thing to have. All right, the next topic is nicotine and tobacco. So I put some picture here, like various kind of nicotine there, and what the nicotine has. So as you can see, from the tip to the bottom, there are different things in each level. Common one is the insecticides, vinegar, batteries, like all kind of mixture product is there. But some people say, oh, it's not a big problem. I can stop it anytime. That's the worst addiction. It's kind of hard to quit. The most dangerous chemical is the cancer-producing tar. Okay, that eventually causes lung cancer. So what are the consequences? As you can see, heart disease, lungs problem. A lot of young people, when they start vaping or smoking, they start having asthma attack, and they don't tell their pediatrician that what they're doing. But pediatrician, our doctor, we try to ask this question because we eventually find that. That is the cause of premature asthma at that age. Usually, asthma starts in the early childhood, but when someone like a teenager comes and start having asthma, most likely they're having some issue with the nicotine or vaping. Okay, there's some picture to scare you, but just for information. So it can cause stomach cancer, esophageal cancer, oral cancer. You see that how that gentleman had the throat cancer, lung cancer. Smoking also causes premature baby and low birth weight baby. Okay. Well, there are many ways to treat that, like surgical intervention or chemotherapy, radiotherapy, those kind of things. But the expectation would be like, if I can survive. As I said, there's a very dangerous cancer. It's hard to treat. You could actually lose your life. Better thing not to use it. Okay. Why is it so hard to quit? Tobacco users often get hooked on nicotine. The drug in cigarette, all those snuff, chewing tobacco, it's hard, as I said earlier, that it's kind of very hard to quit because it impacts our brain hormone called dopamine, that happy hormone. So it can impact that. So it's kind of become very addictive and hard to quit. Okay, the next one is marijuana or cannabis, okay? Is cannabis, is very getting popular nowadays, even though, some medical provider will say that it's helpful. Yes, there are certain conditions helpful, but American Psychiatric Association, which I'm a member, we do not recommend cannabis for anything, treatment of no psychiatric condition or anything, because we know that it's a very addictive and it has a very long-term and short-term impact. The next one is the bath salts. Bath salts is another kind of like a similar to amphetamine or methamphetamine or ecstasy, but it's kind of a what do you call designer drugs. You heard about all those horror story, like they becoming like zombie or killing each other, biting each other, those kind of things happening. But nowadays we don't see that much of bath salt use locally. Maybe people kind of got scared of it, but it's kind of there. So basically it causes extreme agitation, hallucination, delusion. I've seen few people like even after use of bath salt once, they got hooked to that, and they had psychotic episode and had to be in the hospital for 6 weeks to get better.
So like bath salt, something for people to get light.
You can say something I can
Is
hear.
it like to feel good, like to relax? Was it?
No, it was not to feel relaxed. It was to feel more hyper. It's like, I have a lot of energy, I'm going to do a lot of things, I have exam coming, I'm going to try it so that I can stay up and finish like cramming my, subjects that I haven't finished before. People has a lot of different, their own reason for using drugs. So, it's not common in teenagers nowadays. As I said, it's kind of not that common, but that is one of the risks there that, it can cause. Methamphetamine. Yeah, so methamphetamine is very common in this area, especially our Northwest Arkansas. We noticed that, when there is like a working class, like a lot of factories, a lot of like plants, Tyson or chicken plants, those kind of, where there is a higher chance of methamphetamine use. But the bigger problem now that it's kind of getting laced to other drugs, like, especially like nicotine vape or marijuana, and that's how we see a lot of patients who comes to the hospital. They said, "Oh, my, vape was laced with meth." So it has very others name, as you can see, ice, crank, chalk, crystal, many names. Even Tina, that's interesting, right? Okay. So what happened with meth use? Short term, patient feel like, more energy, focus, hyperactive, rapid, irregular heartbeat can happen. That long-term effect is the biggest problem. As you can see, patients lose their teeth, like really bad teeth. They have skin wounds, like it seems like some bugs bit them. And sometimes actually patients get delusional. They feel like that there are bugs under their skin and they started scratching to get the bug out. It's called delusional parasitosis. Eventually, main issue is the brain. Brain becomes pretty much fried. Those terminology, brain fried. Yeah, so brain gets like, kind of like, Alzheimer's disease. And the immediate biggest problem is that patient actually can have epilepsy, like they can have seizure and they could die from, like suppose someone got high on meth and driving, and just imagine, they could have a seizure, they could die themselves and they could hit other people and kill themselves. All right, so look at that. These are the meth phases that can happen from that. And unbelievable change. 3 months later, look at that gentleman, how it happened. Age 48, how the patient was looking, and 52, 4 years, how they're looking now. So there's kind of the impact of methamphetamine use. Okay. Heroin. Heroin is kind of, pretty common that I'm getting a lot of patients actually lately. I don't know, maybe somehow the recent population or, kind of trend happening, but heroin is kind of a downer kind of medication that we kind of mentioned earlier. But the biggest problem with heroin is that patient could die, just overdose. They don't know how it is going to impact. But most of the time, patients use heroin and they never wake up. It's kind of very dangerous drug. And just to add to the heroin, the pharmacological opioid medications. I mean, it's very common in this area or anywhere in the United States. It's a kind of an epidemic, here. And a lot of deaths happening because somebody gave someone a pill, say, oh yeah, try this, and it was laced with fentanyl. So fentanyl is a synthetic opioid, which is actually 10,000 times probably more potent than heroin. So just imagine what could happen. I actually met with a parent whose son went to camping, and they were camping, and next day they found him dead because he was having stomach ache or something, and somebody said, oh yeah, take this pill, it will help with your stomach ache. And he never woke up. So it's very dangerous. Cocaine, cocaine is a stimulant drug, and it kind of very old drug that it, have you heard, guys, that once upon a time that Coca-Cola used to have cocaine? Yeah. Right? Yeah, so thanks God that they, banned it. Yeah, but so it's kind of same as like methamphetamine, but it is more kind of addictive, and it kind of caused the same problem, like seizure, cardiac arrest, death. One of the things that we see the patient coming to the ER with heart attack kind of symptoms, and we always take the history if they're using cocaine because we have to treat them differently. All right. So what is the difference between crack cocaine and the cocaine? Crack cocaine is like, they add some side thing like baking soda or some kind of thing to make it more potent. Actually, crack cocaine is more potent and dangerous than the regular cocaine. And it's cheaper, so, low socioeconomic people, they use that more. Ecstasy. So ecstasy has another name, MDMA. The other name, ecstasy, Molly. So it has like a name for called rave drug. So do you know what's rave? Yeah? So rave is kind of like a party where people play techno music and they use the ecstasy. But the dangerous part of that, often we see people die in this party from heat exhaustion, like renal failure. Their kidney shut down because they become so hyper, they dance so much that they don't hydrate themselves and they get kidney failure. Somehow that thing kind of, yeah. So it's kind of the impact of like I think it's LSD. So LSD is a drug, hallucinogen, and it was invented during Second World War, actually, the history-wise, if you want to know, for the Nazi soldiers. But then it used as a mind-controlling drug, but somehow it became out in the public and people started using it because it caused severe hallucination, especially color distortion. They get really psychotic, like they call it trip. Yeah. Yes.
So would you need to take large amounts for that for illusion, or just?
No, very small amount. You see that how big is that thing on the person's mouth? It's like a tiny bit. It's very potent, and patient can have persistent hallucination even after many months. Have you guys heard about that airline pilot, Alaska airline pilot, who shut down the plane flight because he was having hallucination? Yeah. So he used most likely the LSD. So it's called, hallucinogenic persistent perception disorder, HPD. So I already kind of talked about the prescription drugs. So pain medication, self-medicating. I mean, I've seen people also using cough medicine. That's kind of a very common problem in teenagers, adolescents. Dextromethorphan or DMX. Okay. So there's some of these there that cough syrup or dextromethorphan, it causes the hallucination and it becomes very addictive. So parents, if you're giving your kids cough medicine, make sure that you control it. Yes.
So I heard that people would dilute this cough syrup with like some other drink and add. It was making some kind of drink with the cough syrup because it has these codeine.
Okay, there are various kind of cough syrup. So codeine is like an opioid kind of thing. Okay, so yeah, it can be. So Robitussin, the one that commonly sold at dextromethorphan, sold at the Walmart, pharmacy. That's the Robitussin, yeah. So. So I actually had the steroid slide, but somehow it washed out. So abuse of anabolic steroid may lead to aggression, paranoia, jealousy, delusion, impaired judgment, stemming from feeling of invincibility. A lot of time I see patients who are using steroid coming to the hospital in mania, like a very manic episode and psychosis. I mean, they have really rage. Simple thing kind of cause them to get angry, agitated, maybe assaulted also. So yes.
So really, but what if you only take it once every year, just like a short amount?
Well, some people actually get steroid shots for various conditions, but it's not going to be a problem. It's like, remember I said initially, persistent using more than you need, and then kind of develop tolerance.
then it becomes addictive. So Dr. Wagle give many baby steroid shot for some pneumonia or some kind of infection to prevent that. We do that, but that's not going to be a problem. Yes.
So is this talking about more about steroid usage within teens?
Yes. Yes.
Yeah, this is the premature self-inoculation. So if you're already mature, you use the steroids.
Yeah. So if you use it before age 18, it can cause fusion of the growth plates. And you're not going to get taller. You're going to get bulky and, yeah. Yeah. All right. So, just kind of to scare you again, some of the famous people that celebrity kind of died from using drug, it's kind of really, surprising that they had some problems. So everybody, there's some aspect, like in every society, everywhere there is drug use problem, that we need to be just vigilant to not fall into that crack. The most recent death was, who was that? A One Direction singer? Huh?
Liam Payne.
Yeah. Liam Payne, right? Yeah, yeah. So, he died because of drug use. Just think about it. I mean, he had the great life, right? Fame, money, everything. The drug problem finished the career, life, everything.
Matthew Perry.
Yes, Matthew Perry, yeah. From the Friends, yeah. Yeah. I mean, Dr. Wagner always talked about that, what could happen with the drug use, miscarriage, low birth weight, birth defect, developmental problem, all those things can happen. The alcohol causes fetal alcohol syndrome, if mom used that. The main issue is kind of like, that lifelong problem with the children who are born for, pregnancy time drug use. I mean, I see that all the time, especially fetal alcohol syndrome due to, mental retardation or intellectual disability. That's a big problem. Okay. So what is the consequence of drug use in the society? As you can see, crime, drug possession charge, trafficking, manufacturing, resulted in, of course, massive prison population. USA has the highest number of prison population in the world. And, that kind of reflect other way. All right. Oh, sorry, I cannot see. I don't know why this is happening. So how to prevent the drug use, right? It's a very important slide that I can see it in anything, but I can tell you like what is there. So how to prevent fall victim of drug use? The first thing is say no. Like if you get peer pressure or anything, just say no and walk away from there. Like I have a teenage, children, like my daughter and my son. I mean, that is the one thing that I worry about, that if they get exposed at school or whatever with their friends, that the best way to deal that is firmly say no and say, I'm not going to be using that. Yes?
What do they force you to do?
Force? Well, I mean, that's going to be a legal matter. But as I said, like, scream for help. Don't just be quiet. Okay? Even don't take anything. Like, say, hey, here's a new gum, try it. Don't do that, because you don't know. I mean, what could be there? Unfortunately, that's kind of the situation nowadays. Talk to parents. If you have any question, talk to your parents. We are here also, talk to a therapist, counselor, whoever, you feel comfortable talking. doesn't need to be parents. It could be aunt, uncle, whoever you feel comfortable to talk. Yeah, so build self-confidence, make positive future plan. Brave enough to say no. Surround yourself with friends who these are good guys. So that's kind of the biggest thing. If you kind of sense that this is a wrong crowd, you don't need to hang out with them. I mean, if you have fear that they're gonna abandon you or you don't have friends, you'll find new friends. You don't have to be with those friends. You were not doing the right thing. Sorry, I cannot wanted to show you the. Okay, so it's kind of like a MRI, like functional MRI. Probably not for you guys. It's going to be a little bit more. Okay. So, is it worth the risk? Trying a drug might cost you much more than you bargained for. The death. You don't want that. Premature. All right, I think that's probably enough for scaring you. But if you have any questions, let me know. I mean, I actually trying to keep it like non-medical. I mean, if you have any medical related question, I can answer those, but just trying to be like, informal information. Yes?
Does the caffeine in the daily
Yes.
intake of tea, like typically let's say you drink 16 ounces of tea every day, does it meaningfully affect any metabolic risk or cardiovascular risk?
Of course. I mean, Indian tea, you have a lot of milk, sugar, right? So there's a chance that you could end up with hyperglycemia or elevated sugar. But the biggest problem is tea is not that much problem because tea doesn't have that much caffeine like coffee. So limiting coffee, 180 milligram or less than 200 milligram a day is enough. I actually drink like 3 cups, 4 cups a day. I developed like a dependency or tolerance on that. And the biggest problem with that nowadays is that with the teenager that they're drinking supersized energy drink, and those has like, God knows, I mean, like 6 cups or 8 cups equivalent of caffeine there. What is that, Monster? That big Monster, like this big? Yeah, right? So it's not just only caffeine. Those energy drink has sugar and a lot of sugar, and that can lead to diabetes. So, probably not a good idea. All right. Yes.
Can you talk about marijuana-induced psychosis a little bit and how it affects younger adults and like onset?
Yes. So, research showed that if kids using cannabis before the age of 14 frequently, and that's kind of the cutoff time, age 14. Before that, they have higher chance of developing schizophrenia, and schizophrenia is the primary psychotic disorder, which is irreversible at this point. So that's kind of a really big problem. And the primary sign of psychosis in cannabis use or marijuana use is paranoia, which kind of patients started, questioning about their family members' intention or paranoid about their family members, like, oh, they don't love me or they're trying to get me in trouble or this and that. So it can happen very early age, in teenager cannabis use. Yes?
Can the over-the-counter medication, pain medication, will become addictive if taken often?
Usually Tylenol or acetaminophen or ibuprofen, those kind of medication are not addictive. But remember what I said, that if someone keeps using some drugs and anything more than a recommended dose and they need more and more to get the same response they used to get, it could be cause problem. Like I have seen people overusing the nasal spray, you know, the Afrin to prevent your nasal congestion. People become addicted to that. Yeah, it happened. I've seen that a 70-year-old lady, she need 6 times a day to use that, and you know, eventually I was able to help her to stop that, but it can be addictive sometimes, any medication. Yes?
How much caffeine is like too much caffeine?
So 180 milligram, 200 milligram, less than 200 milligram would be okay, but more than that would be problem. All right, I think, you know, I'll conclude here. If you have any more questions, we have some folks out there who can help you further, okay? Thank you.
Thank you so much. Thank you for your expertise on that. That one more topic, I'll be finishing it off for today. So I'm Raj Dondedi, I'm a primary care physician. I have been with in Northwest Arkansas practicing for 15 years. So today I'm going to talk about lifestyle diseases. I know this is something that a lot of our community members have been going through, and I wanted to get some light on this problem that has been getting worse and worse every day, every year. The reason being that this is the disease that happens because of our lifestyle choices. What it means is it's a condition where we make a decision about our health, and unfortunately it is not the right decision that we made, and as a result of it, we end up with consequences of that poor lifestyle, diet, or socioeconomics, or any kind of consequences or the issues with the cultural aspects that interfere with our health. So one of the common things that why do we have to worry about these lifestyle diseases is because of the statistics that scare us. If you look at it, Indians, or people of Indian origin, have a 27% risk of developing heart disease or sudden heart death when you compare it to other population. That's a number that would scare anybody. And the problem with that is also you see that we are seeing that at least 5 to 10 years earlier that it is happening in our population when you compare to the rest of the population. The same thing with diabetes. 23% of South Asians, especially in Indians, are having diabetes at a significantly higher rate when you compare it to other population, especially Caucasians or non-Hispanics. And the third important thing that we are noticing is the cancer risk has been significantly going up in the last few years, I would say in the last decade, because of our lifestyle changes that are happening and the significance of mental health issues that we already Dr. Rahman has talked about. So these are the risk factors that we are seeing why the heart disease is happening. Our diet is the biggest contributing factor, and our Indian diet is high in sugar, salt, fried foods, food that has been rich, and that's not the kind of food that we are used to, because back the kind of food that our grandparents ate, they had a hard labor that they used to work in the fields, and they had the need for using a high carbohydrate rich diet. But in our case, we pretty much sit in front of the computer all day. We don't do much physical labor, but we still consume the same carbohydrate rich diet. And that's the reason why we are seeing the spike in these lifestyle diseases, especially the insulin resistance, the cardiovascular diseases like the heart disease and everything. These are the kind of issues that will progress to the point of severe disease. And when it happens, we don't have much of a choice other than just be dependent on medications and everything. And the thing is, when you look at the disease process, it starts at a very early stages without even realizing it, because let's compare it with the coronary artery disease. Most of the blood vessels that we see, most of the blood vessels that we in our heart, they don't have any blockages or anything until the age of 50. That's what the usual pathophysiology used to be. But in the last 10 to 15 years, we are seeing that the blood vessels start developing this, what you call as a plaque, and the plaque starts developing over a period of time, and that reduces the size of the blood vessel to the point that it blocks the oxygen supply. When it comes to a complete blockage right here, that's when people end up with a heart attack or heart failure. That heart attack is what causes the death, and the biggest problem for our population is that it not only you have a blockage, but it causes inflammation around this area, and that reduces the size of it. And people that have heart attacks, when you compare it to other population with Caucasian or white people or non-Indians, they can survive 2 or 3 or 4 heart attacks. But the first time death happened, the morbidity or the death incidence of death in Indian population is way higher because of the way how our blood vessels react to the blockages. If you see it, if there is just a blockage, there is still enough supply for the blood to supply the oxygen to the heart. But in our population, what we are seeing is the swelling happens to the point, not only the blood supply, but it basically causes a severe reaction that it automatically blocks it and causes severe death of the heart muscle, leading to heart attack. And most of these are prevention. These are preventable diseases that have very significant impact, because these are happening because of the lifestyle that we are following. And if you look at it, what are the things that we can do to prevent it? And one of the basic things is a balanced diet. We have to move away from a high carbohydrate, high sugar, high fat diet towards a high protein and a low carbohydrate diet. When you say high protein, because most of us consume vegetarian diet, there are still good sources of protein that is still healthier, and it still is a beneficial diet plan when you compare it to a high carbohydrate diet. Generally, traditional vegetarian diet in our Indian culture is mostly based on bread, rice, noodles, chapati, roti, dosa, anything that is more carbohydrate with some amount of protein in the form of lentils, beans. But that has to change, and if we don't change it, that low protein, high carbohydrate causes inflammatory changes, causes these kind of lifestyle problems. The other thing we have to do is exercise. We as a population, we are seeing that we do exercise a little bit more, but the kind of exercise we need to do is to be addressed as well. One, walking is a good thing, at least we are moving, but make sure you have a goal of reaching at least 10,000 steps per day. Just walking leisurely is not going to make a huge difference, because the idea behind exercise is to increase your heart rate. What does it do? It increases your metabolism. When you increase your metabolism, you increase your heart rate, so you burn more calories. And the other aspect of it is resistance exercise, which is lifting weights. Because when you reach the age of 30 to 40, you lose muscle mass. We start losing muscle mass. And especially both females and males both start losing muscle mass. And as a result of it, your body weight is being transformed from a muscle dependent to a more body fat. So that's the reason why we start developing body fat around your abdominal area, and that is the biggest risk for heart disease. And not only heart disease, but also diabetes and other cardiovascular diseases like hypertension. So staying active, getting at least 5 days of moderate physical activity, stretching exercises, these are all the important things. Quitting smoking, limiting alcohol definitely plays a role. The other thing is, the lack of sleep and the work-life balance. That is the biggest, that is also a common theme that we are seeing these days with our double jobs that we pretty much are doing. You have your day job, and then you have your offshore team that you have to take care of in the night time, and pretty much you are sleeping at odd hours and waking up. Take care of the kids in the morning, so you are sleeping in breaks. You are taking 2 or 3 hour naps rather than going into a sleep cycle where you have to go through different phases of it. You have to have a, what do you call it, a REM sleep cycle, where your brain gets your sleep, your rest. When it goes into the deep sleep, that's when the brain gets rest. If you don't go into that, and if you stop that, if you're taking naps, your brain will never get that quality sleep, and you always feel tired. When you are tired, your brain is not functioning as the way how it should. And that brain fog, the difficulty focusing on things, these are all the effects of lack of sleep. And lack of sleep has shown to increase the risk of dementia, which is memory problems. And that's the reason why, of all the things mentioned, lack of sleep would be a big factor. And so make sure you focus on your health as much as you focus on your sleep as well. So how can we prevent that? Not only those things.
Raj, one question.
Yes.
Could you provide the early symptoms of identifying the blood vessel inflammation?
Unfortunately, these are the diseases that don't show much of signs unless they are farther away in the disease process. That's the reason why we talk about preventive screenings, because when you are 30, that's when things start changing in our blood vessels. That used to be back in our generation, not in our parents' generation, or the previous generation, they used to see it in 60s and 70s. But we are seeing it in almost 20 to 30 years before that, just because of the lifestyle changes. And we don't see much of the changes. Let's say people say they can feel their blood pressure. No, by the time you are feeling the blood pressure, it has already caused the damage to the blood vessels. It has already caused damage to the eyes, to the heart and everything. So don't wait for symptoms. None of these diseases show symptoms at early stages. Your health looks like. So these are the common tests that will definitely help you understand what your baseline health is. A complete blood count will tell you what your hemoglobin is doing. A complete metabolic profile will tell you about how your kidneys are doing, what your electrolytes are doing, what your liver is doing. A1C tells about your glucose levels, the thyroid profile, the cholesterol. In a recent study, there was a clinical evidence that talked about vitamin D and what vitamin D was showing to the health of the population. And in my practice, almost 90% of our Indian patients have vitamin D deficiency. The reason being that we pretty much stay indoors during our work, and for females, the lack of exposure to sunlight and our worry about if we go outside, it will get dark and we don't want to go outside. So that prevents us to get adequate sunlight. We evolved to be in a population, in a country like India, where you get almost 300 days of sunlight. And back when we were there, we were exposed to enough sunlight that your body was able to produce that. But in our current lifestyle, that's not happening. So that's the reason why everybody should take vitamin D. Not only for your muscles, not only for your bones, but the recent study had shown that it actually shortens the length of your telomeres. Telomeres are these ends of our chromosomes which help to repair our chromosomes. So whenever there is a damage, so let's say you have an infection, let's say you have a inflammation, these telomeres acts like a repair function, and then it repairs the thing. And vitamin D deficiency has shown to reduce the effectiveness of the telomeres from doing it. So vitamin D has shown to increase the lifespan of the chromosomes and help in increasing our overall lifespan itself. So definitely that is something you need to focus on. Vitamin B12 is another deficiency. We see it a lot, and it's a common thing because of our vegetarian, mostly predominant vegetarian diet. And vitamin B12 is a neurodevelopmental factor. What it means is it is needed for our nerve development. And people that have B12 deficiency can have increased chance of nerve degeneration, early onset of dementia, and it is a fairly common thing even for people that eat non-veg. The reason being the kind of foods we eat causes what you call as chronic atrophic gastritis, which is inflammation in the stomach that produces gas and all these problems. And as a result of it, the body doesn't absorb the B12 vitamin as much as it should. So make sure you get your vitamin B12 checked, and if you're worried about your animal protein intake, definitely go ahead and take a B12 supplement. Over-the-counter B12 is sufficient enough. Very rarely that people need a vitamin B12 injection, but most of us, it's a good idea to take a B-complex vitamin that has B12 in it. And the cardiac markers that I'm talking about for people that have an increased risk. If at your age of 30, when you go to get your physical, and if you start noticing that your cholesterol is running high, you tried all the lifestyle changes, you worked on your diet and everything, if they're not getting better, or if you have a strong family history of heart disease, go ahead and get these tests. Ask your doctor about getting at least these 4 tests. These high sensitivity C-reactive protein, apolipoprotein B, lipoprotein A, and CT calcium score. These 3 are blood tests, and what they tell is the inflammation that is happening in your blood vessels. And these tell things that your body is not able to tell right away. And if you notice any of them are on the higher side, that means that your body is in the process of developing blockages. And the CT calcium score is a CT scan of your heart blood vessels. And what it is telling is how much that inflammation has caused permanent damage to you. So if you have all of them on the higher side, it's a high chance that you will end up with a heart attack sooner or later. So the higher the numbers, the more riskier you are. The other test is a kidney test that tells about what your urine microalbumin levels are, and it tells how good your kidney function is. Females should get a mammogram after the age of 40 because mid-40s to mid-50s is when the breast cancer risk goes up. Besides that, they should get in their pap smear, which is a cervical cancer, which is something that can be prevented with the HPV vaccine that is given for girls below age of 15. It is approved up to the age of 40, so females can get it after that too. But it is recommended for the age 15 or below. Colon cancer screening. Previously, we used to not see colon cancer as much as the Western population used to, but in the last several years, because of our diet that we follow, the processed foods that we eat, definitely the incidence of the colon cancer has gone up. In my practice that I've seen, at least let's say if out of 100 people that have done colonoscopy in our Indian population that I'm talking about, at least 50 people ended up with some sort of a process where they need to go back and recheck it again in a few years. Generally, colonoscopy is recommended once every 10 years, but some people develop what you call as polyps. Polyps are these precancerous growths that if you take care of them early, then the chance of developing into cancer goes down. So, I mean, the diet itself is one of the biggest factors. We don't see a strong family history of it because, you know, in the previous generation did not have it, but we still need to get this done at the age of 45. Not everybody needs a colonoscopy. There is a stool test called Cologuard that can be done once every 3 years, and that has shown to be very effective in screening for colon cancer. Lung cancer, for people that smoke, it's a fairly common habit that we have seen recently in the last 20 years with younger population smoking, not heavy smoking, but while the rest of the population there has been decline in smoking, we are seeing an increase in our younger population. So both tobacco, marijuana, and e-cigarettes. So please focus on reducing that habit. Quitting it would be the best one. The other thing I want to talk about is the work-life balance. This is the common, again, how do we manage our work? How do we manage our balance in taking care of our health? Every day when patients come to see me, I talk about this. And it's a hard talk about because me sitting on one side of it, and it's easy for me to tell, okay, you need to exercise, you need to take care of your health and everything. But when you have a job that is demanding you to work at least 2 shifts per day, it's hard to maintain it. But at least there are some changes that you have to make that can be helpful in long term. One of the things is, set clear boundaries at about your work hours. That's the hardest one. There is not a real boundary these days between when your work starts or when your work finishes. You are pretty much required to be available all day, and that is a big damage to our overall health. Not just that, for our families, for our personal life, for our psychological health. So you have to start saying no. I mean, if we don't do it, this is going to become part of your daily routine, which is already is, and it's very hard to break it. The second is prioritize and delegate. And we Indians are not good at saying no to anything, so we want to say yes to everything, and as a result of it, we take a lot more than what we should be doing. Delegate it, spread it out, choose the most important thing that needs to be done, rather than doing everything by your own self. You have to seek help, and you have to delegate it. And the blocking time for the family and self. Your work is important, but work is not life. Your life and your family should come first. When it doesn't, then the damage that is going to happen is going to be permanent. And once your health is damaged, how much ever you spend, how much ever time you do, it's not going to come back. That's the reason why make sure you spend adequate time for yourself. The other thing that we are seeing is the digital time off. What we are talking about is the gap. You have to get away from electronic usage at least 2 or 3 hours before you go to sleep, because you cannot be having your phone next and expecting any email, text message, or anything to be answered at work or anything. Then you are already extending your work hours. So, and that is a common theme that we see in our population. They don't care as much as we do about extending that our call schedule. So focus on getting away from the electronics at least 2 or 3 hours before going to sleep. And flexibility or the 9 to 5 hour time definitely helps, because that way you can stagger the hours, you can work on the things that you care about, and then make sure you can focus on the important things and then get away from work at the earliest. And share the load at home. Unfortunately, that is the common problem. Although both husband and wife are working, a lot of work at home is still being taken care of the ladies at the home. Sharing that work burden helps ease out the tensions, ease out the misunderstandings that arise from the work hectic schedule these days. One of the common reasons why we are seeing an increased incidence of marital discord, even to the point of divorce, is because of the work-life balance and the lack of communication that is happening, and the feeling that one person is doing more than the other, and then that constant feud between each other is what triggering it, and there is no easier way than sharing the responsibilities as much as you share your life together. And the stigma around seeking help with professionals, mental health professionals. We are all humans. We all have emotional ups and downs. But when we are in a situation where we cannot take care of ourselves, there is professional help that is available, and we all should reach out to it. As a community, we see that there is stigma in talking about those things, and when we don't, it's very hard for the people around you who are well wishers for your health, but they don't see that. And we've seen huge number of cases of psychiatric problems that just go under the carpet without even realizing it. So seek help from professionals, from mental health. Your job provides you a good source of online facilities, and these are not things that you are sharing with others or anything. This is a personal interaction that you have with you and your therapist, and it helps a lot to focus and helps you to take care of those stressors that does cause these problems. So, what are the challenges that we face with this to maintain work-life balance? Is the sandwich generation. We are here taking care of our own lives, taking care of our family here, while our parents and our older generation is there, and we are always feeling the guilt of leaving the parents there and not be there and not available for them to be taken care of. And there is no easy answer for it. And then the always available IT culture that we talked about. So you've got to say no, and you have to have a clear boundaries. It's hard, but as a group, if we do it, there is always that chance of the companies and the higher-ups noticing that it's good for the overall development of the company and for the long-term health of the employees itself. So these are the things that I wanted to bring out your attention to. If you have any questions, feel free to tell me. So intermittent fasting is yes, it can help because of the physiology, which is what you're doing is your body is going through episodes of hypo or hyperglycemia. When you eat food, your body produces insulin, and when you don't, your body doesn't produce. Insulin is a growth factor. What it means is when you are not eating anything, your body goes through that fasting phase. Fasting phase is when your metabolism changes, and when it changes, it converts your body fat to be available to be used for the source of energy. So studies have shown that the extended period of time, maybe 12 to 16 hours, when you fast, you tend to reduce your insulin secretion, which will help you with losing weight while increasing your metabolism for a short period of time. But is it going to be long term? Probably it's not a ideal way to lose weight, but doing intermittent fasting, like a couple of times a week, is shown to help improve, keep your metabolism up.
What about OMAD?
I'm sorry?
1 meal a day.
1 meal a day. It depends on if you are healthy, if you don't have any major medical problems. I think it should be fine. But if you have certain medical problems, it is important to eat regularly. Acid reflux has shown to get worse if you eat 1 meal a day, and people tend to eat a lot more when it is 1 meal a day, and that tends to spike up your insulin levels. So instead of that, studies have shown that eating small, frequent meals spread over a whole period of the day helps to reduce that spikes of insulin secretion, mostly insulin, which is the contributing factor for the diabetes.
If we are taking supplements like B12 and D3, is there a time period where we need to stop, or how do we know how long we need to be?
So generally, vitamin B12 is a water-soluble vitamin. What it means is, if you take it, within a day or two, it will come out of your urine. So there is no chance of it to be very high dose or anything like that. But generally, 1,000 micrograms of vitamin B12 would be sufficient for most of us. Vitamin D for kids, it's about 1,000 micrograms for adults. And when I say pediatric population, correct me if I'm wrong. For younger population, it's 800 units, and then for adults, it is 2,000 units. Generally, taking it with food helps it getting absorbed better. Mostly, if you take it with citric fruits like orange juice or something, it gets absorbed. And studies have also shown that if you take vitamin D3 with K2, it gets the absorption better and keeps it in your body for a longer period of time. And vitamin D is a fat soluble, means that it stays in your body for a longer period of time. So you have to be careful about how much vitamin D you have to take. But studies have shown that a level of 40 to 60 is optimal for your health. If you take too much of vitamin D, it can cause problems like kidney dysfunction, which is very rare. We don't see it, but we have to be careful about how much of vitamin D you're taking as well.
Do we need to stop after a certain period of time, or we can continue?
It's a good idea. With our current lifestyle, pretty much if you stop it, it will go down. Yes, you get adequate sunlight during the summertime, but during the winter time you don't get it. And even if you get enough sunlight, our dark skin actually reduces the absorption of vitamin D, because the melanin in our skin is not absorbing the vitamin D as much as the fair skin person does. So that's why we all have vitamin D deficiency. So as long as you are in this part of the country, you probably will be needing it to be taken on a daily basis.
Are there any supplements other than what you just mentioned that you need to think about, like CoQ10 or things like zeaxanthin, lutein and magnesium?
So magnesium glycinate has been studied. A lot of us have magnesium deficiency. People that have trouble going to sleep, having muscle cramps or high energy levels, seems to have either magnesium deficiency or vitamin D deficiency. CoQ10 helps with cardiovascular health, improving your cognitive function. Yes, there are others that have been studied, but unfortunately there is no hard clinical evidence to prove that taking it is going to reduce it or prevent it from happening. It's more of yeah, exactly.
Is it better to take a multivitamin?
Multivitamin, yes. Generally, once a day multivitamin, as long as you are taking it on a regular basis, you should not hurt. But taking that along with multiple other vitamins will increase your risk of overdosing your vitamins, and certain vitamins are fine because they will excrete out the urine. But but some of them can stay and cause problems. So you have to be mindful of what you're taking as well.
Is there any way to detect early resistance to insulin?
Yes. So the way diabetes develops in our body is because of over-secretion of insulin over several years. So insulin is almost, think about like this is a common analogy I use to explain what diabetes and what insulin plays a role is. Think about the food that we eat converts into glucose, fat and protein, and insulin is like a machine, or it's like a magnet that takes the glucose that's in your blood and gives it to each of the cells. And if you put a piece of iron, a piece of wood between the magnet and the glucose, what happens? The magnet loses its power. So the body has to produce more insulin, which is the magnet. So over a period of time, you are tiring up your islet cells, which produce insulin. So the insulin loses its ability to function as much. And as a result of it, people end up with diabetes over a long period of time. But how do you know whether you have insulin resistance is generally when you do fasting insulin levels. If they are on the higher side, that means that your body is producing more insulin than it should be. That's an indication of insulin resistance.
Yeah. Just like to take a few minutes to thank, Api coming over, spending half of the day, Dr. Raj for organizing this, Dr. Samir Wagle, and then Dr. Pradeep Palate, and even Dr. Rahman and Dr. Kilambi, who had to leave for other things. I think the whole half a day was very educational, from preventative things to obesity, drug awareness. I could see a lot of engagement on even from childbirth, things to take care, to drug awareness, and all the other sessions that we had. This is second year we are doing this, so please provide your feedback on how we can improve this, and we would really like to continue these things and provide this information to the community. As you know, I think Dr. Raj said it well, we are here, but our genes are still different. So having that kind of information on what we need to do, I think is very informative, because we definitely are not the same as like everybody else, and having that awareness information. So thank you everyone for coming over and spending your time, and especially the API and the NAMNA who helped, combined with ICANWA hosted this event. This recording is available on YouTube, so if you'd like to share it with your friends, they can definitely watch all the sections and get the information also.
Thank you so much for giving us the opportunity to give us